Welcome to the Do Something Admirable podcast. My name is Alex. My patients call me Dr. Watson, or also Alex. This podcast is both a play on the name of our medical practice, Admire Medical, and the previously unspoken mission of the practice. We help our patients start their next chapter after life-changing events, like amputations, brain and spinal cord injuries, and cancer treatments. This show is for anyone looking to be inspired and then inspire others to do something admirable.
Alex, tell us about why Admire Medical is different.
So Admire Medical is the long-term intersection of a bunch of different plans I'd had going through med school and residency. Even when I was in undergrad and business school as a personal trainer, all kind of met here. Admire Medical is a nice program. I'm obviously biased, but what we end up doing is integrating what were typically silos in medicine. There's a lot of folks who make their whole career on weight loss counseling and that area of metabolic medicine, which is obviously critically important, but don't have a ton of training in the rehab medicine side of things. And to better understand the full continuum of disease progress and things like that, it's really good to have that back end. Well, here's where these things go if untreated, but also most folks aren't in the early stage. They've usually been dealing with these comorbidities from weight-related issues for a long time. So having my primary training in physical medicine and rehabilitation, where I deal with folks with chronic back pain, end-stage arthritis, before, during, or after strokes, things that are very related to these issues, well, now I have that perspective and that training and a good understanding of treatment for those issues, and then the longer term view of what we can do with that metabolic medicine. How can we intervene on those metabolic issues to have the biggest effect on what that end pathology might be, the joint pain and everything. To get to that point, through residency, I was trying to figure out the way to connect the dots between these two the whole time instead of them being parallel tracks that never really met. And so I did my best to let a grand rounds on how obesity medicine overlaps with PM&R. I did all my elective rotations in different obesity clinics around Pittsburgh, both a surgical practice, family medicine based, mostly counseling, lifestyle changes, an endocrinology driven. Here's where the real thyroid issues before and after are a factor. And then also a private practice, very patient-centric, all about convenience. Come in, if you have a good plausible case for needing weight loss medicine, we provide it and you can move on with your day kind of thing. So less about the counseling and more about just giving you that tool and then you take it with you. So I built those experiences along the way to eventually have a really good toolbox when dealing with this in the PM&R context.
And that's a very different way of looking at things, right?
100%.
Because I can tell you, going to a doctor personally, that's not the experience, right, over the past 15 years. So that is a very refreshing look at the way things are being done. And the practice itself is important. And people want to know you, right? So tell us about Dr. Alex.
So, kind of touched on it a little bit before, but to get more depth, I went to school, as an undergrad and studied marketing only. Took one bio class for business majors, which basically taught you that there are cells in the body, and there's something called the mitochondria in there, and that's about it. And I enjoyed it, but was focused more on going to the gym and trying to focus on the business concepts that might be fun and creative and marketing and that kind of stuff. Ended up graduating and worked in marketing for a bit, didn't love it enough, and the whole time wanted to do something sciencey. So I went back and I worked at a psych hospital for a year and a half or so to really get just a good picture of what any area of medicine would be like, and working with patients in their most vulnerable state. And what I really got from that one was the communication skills and feeling comfortable speaking with somebody about very personal topics while they're in a lot of unfortunate distress because of that. So very quickly took away any nerves that I have in similar rehab-related scenarios where you're counseling somebody on their new spinal cord injury and they're coming to terms with not ever walking again, or similar things with strokes. Actually, last week I had a case where there was a woman who had a stroke 2 months ago, and no one had told her before that she was likely not going to ever gain the use of her arm. And so having to have those kinds of conversations with somebody who's both acutely affected by that injury or whatever it is, and then also trying to get out of the present moment and look downstream and say, listen, unfortunately, you're not going to make that recovery, so our priority now has to change, instead of towards rehabilitating that injury, more on how can we accommodate those things.
Explaining a path, right? Like that's the big thing I see about you, is you just don't give the fact, you explain the path, and I think that's one of the things that sets you apart.
Thank you. Yeah, I try and shoot straight with this, which does mean breaking some bad news sometimes, but also once you get to that point, you get the bad news, that's when you can start moving past it. If someone's always dancing around diagnosis or dancing around and saying, well, there's a chance, you unfortunately, that might either set false hopes or just delay the eventual cathartic moving past it and figuring out what comes next. So that was the psych hospital was a great experience, and then I ended up doing pre-med at UPenn. I needed a bigger name to try and get into med school with how competitive I heard it was and everything. So I did my 2 years there and worked at CHOP at the time, and realized I definitely didn't want to go pediatrics route. That was rewarding, but not for me. Went back to another year at the psych hospital while I applied to med schools. Got into med school, and then at that point I was like, I still want to get a little more business education. And my GMATs that I took as a senior, as an undergrad, were expiring that year. So after years of working towards getting to med school, I had to defer for a year and do my business school year. Otherwise, I had to retake the GMAT and didn't want to deal with that. So really, really honed my delayed gratification skills here, because it's just constantly like you get to where you thought you were going and then have to pause that and knock out some prereq or something. Did my year of business school, then 4 years of med school. Went in there thinking I want to do orthopedics. I liked those like myoelectric prosthetics, the ones that integrate with the nerves and muscles and you can control with your mind kind of thing. Thinking that ortho was the way to do that, but then realizing it's actually PM&R. And surgeons go to work really early. I just didn't want to be walking in at 5 a.m. every day. And the culture too, they were not quite as warm and cuddly as I like. Discovered PM&R after my surgery rotation when I thought I was out of hope here, and like, I'm not going to find something I love, and then just saw that it was literally a specialty of hope, and that everyone, the whole point is trying to find the way out of this acute decline in function and independence and everything, and how can you get back to restoring your normal life or a new normal life for you. And then moving into internship, I was wondering how the heck I could combine some of my old interests of exercise and nutrition and things like that, knowing that there isn't a ton of education during residency about those things. I mean, you'd think that it being so integral to almost every specialty, we get good nutrition counseling, good exercise counseling, but even in PM&R, it's still like maybe a couple lessons over the course of 4 years. So I tried to figure out ahead of time what I could do to get that understanding and credibility, but at the time it was less about the CV and more about just really understanding it to apply it later. And so that's when I figured out that combining obesity medicine and PM&R would be a great way to maximize that benefit. So I spent the next couple of years, like I said, getting that experience in different clinics, published a few books on obesity and back pain, or back pain after a failed surgery, or a grand rounds lecture that I did for my department, and then there was an adjacent spine PT program that I think 1 or 2 people in my lecture saw it and thought, hey, this would apply here, so why don't you give it to them too. So I had to try out the material a couple times and in different audiences and refine my approach to that. And then the last piece was that at the end of residency, I was thinking I need a good resource that I can use or I can give to referring physicians and really show why prehab is different than some of the other specialties. And eat well, exercise, control diabetes, like that's integral to most medical specialties. But in this case, a big part is that it's on a timeline, so you have a certain period of time. And so I wanted to have a resource that could concisely describe these things. And I was going to my 4th year residency and thought, well, I'm going to write this thing anyway. So why don't we propose it to a publisher and see if we can get them to formally help us promote it. And my pre-ab mentor at UPMC and I put together a proposal, and it was accepted by one of the big science book publishers. And so we're wrapping that one up now, but it let me draw in experts in very specific areas of prehab. So, a good friend of mine, Jim Eubanks, he did his fellowship in non-interventional spine and value-based medicine at UPMC, and his big niche was also prehab, knowing that rehabilitation is a core component of value-based medicine. It helps, get more bang for your buck, essentially, is the whole point, and that's where medicine's going. Is how can we, extract the most benefit out of the least amount of resources, because in this country the expense is running away and the outcomes aren't following that. So Jim, I drew him in. It was kind of like assembling the Avengers here of this prehab book. I found Jim for the back pain, and he brought a team with him, and same thing for my co-editor, Dr. Barr. She's a specialist on prehab for organ transplant, so she did our transplant chapter. I worked with the local bariatric surgeon, and Dr. Halbert and I ended up putting together the bariatric prehab chapter, and yada 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 for the whole book, and ended up being this nice resource that I'll be able to recommend to patients and to other physicians. And then as I was writing that, and I had a little more free time as I was preparing for a move, and I had the nervous energy, so I wanted to do something else. I took what I was writing for that and then basically translated it into normal people language and tried to make a patient version of that one. So that one's also wrapping up right about now, actually, and should be out sometime around August. And so I'll be able to give that to patients and have a digital version for that too, and hopefully an audiobook.
And that's why I love getting to know you, because we're going to talk about the book in a lot of upcoming episodes, and you're less about the prestige and more about the education, which is as I get to more know you, that is clear. But let's talk about the continuum of care, right? The core nuts and bolts of what Admire does. Who is that ideal patient, and how are you helping them?
Oh, that's a really good question. As I implied with the book, there are tons of different ways that prehab is appropriate. But kind of the typical patient that we get that is a real good prehab candidate is somebody who has struggled with their weight for a while, and because of that has suffered. Typically it's a joint related issue. That seems to be kind of where a lot of the prehab focus is, because you have this double-edged sword. Someone's got, typically carrying a lot of extra weight, joint pain in multiple joints, and needs to replace one of them. Definitely that's the whole point of why they're here. Replace one of them. Tough to control diabetes or blood pressure or something like that, and they can't exercise because of their bad joints. So how the heck do you kind of chicken and egg this one where the weight loss will make the pain better, and so you can exercise more, but you can't start the exercise component of the weight loss because it's just everything hurts too much. So we work with those folks to, really a lot of the weight loss comes from the nutrition side, not the exercise side, to start at least. And so we design a really core personalized nutrition plan here to get folks to be able to control their calories and not really feel quite as restricted. As a tangent I go on a lot, is that no one diet is right for everybody. And the whole point is that if one diet works for someone, it's because all that's doing is it's letting them stay in a caloric deficit without feeling like they're in this deprived state all the time. So someone who finds that intermittent fasting works really well for them, it's not that the intermittent fasting is some magical diet, it's that they just don't feel restricted on that diet and can stay on it for a while. So we long counseling sessions to figure out really what is going to make this person feel still in their normal state, but also nudge in the right direction. Stay consistent, exactly.
Yeah.
Because like everything in medicine, it's the consistency that matters. So if you're making a huge change and only able to do it for 3 days a week versus a modest change, 24/7, the second person can do a lot better. So we start out by finding that nutrition optimization, whatever exercises that person can do, and then what about their medication list maybe isn't the most elegant for treating their whatever the medication's for, but also is it contributing to weight gain? Is it contributing to worse diabetes control? Is it contributing to fatigue, or is there just a better option out there? In some cases we have medications for mood that may help with just feeling well enough, and then that empowers them to stick to a diet, but there might be some medication that is equally efficacious that also helps suppress appetite, things like that.
And I love how you're attacking not the, obviously there's hereditary things and there's chronic stuff, things like that, but you're attacking the weight and health side of it, right? Not just putting somebody on a pill. You're really, really doing the education and helping them through the process, and then layering in things as it makes sense. It sounds like what you do on a regular basis.
Exactly. And because like you alluded to, struggling with weight and obesity and things like that, it's more and more we're identifying the genetics of it. It's just a heritable condition like anything else, which is a good understanding because it destigmatizes it too. It's not like one person has had worse willpower of their whole life and all this stuff. It's that the signals that these folks have been dealing with unconsciously are much stronger than those that quote unquote normal weight individuals have been listening to their whole lives. So it's just a different game that everyone's playing here, basically, that their genetics have decided. So over time, that's led to this worsening obesity epidemic in the country because we just have increased access to food, and because of economic development, that's the double-edged sword of that too. Is you don't have this, scarcity of calories anymore. Right. So having that understanding of it and being able to counsel folks through those issues and personalize, their own plan to the world that they live in here, and be able to connect the dots between their mood disorder and their poor sleep and their struggle with weight loss, pulling that from my couple of years at that psych hospital, or someone who just hates doing squats, and they say they have a bad shoulder or something, so they're not physically limited in doing squats, but they just hate doing squats. Well, you don't have to do squats. So you do something else that's going to be equally effective for building the muscle, that'll help control the diabetes and help raise that basal metabolic rate a little bit, and just generally feel better. Because a lot of the benefits of exercise are going to be just how you feel, and that's where you get that positive feedback. And then as you stick with it because you feel better, that's when you start noticing the weight loss, and that my blood sugar is so much better, and I'm sleeping better, my mood is better. And we have a lot of times where going down the continuum of care here, people are getting towards surgery, and they're like, I feel better already. Like, right. Do I still need surgery? And I always say, well, if you were feeling that bad enough, and the surgeon thought so, and the imaging said so, that previously you were bad enough for surgery, quote unquote bad enough, even though you feel well now, it's still worth going through with it, likely in most cases, because that damage is still there, and as we get older, it's tougher and tougher to recover from surgery. So if it's going to be inevitable, let's do it now while you're feeling well. And because the prehab, these folks are one of my surgeon unofficial partners here with whom I work a lot. He was saying that one of our patients literally was dancing into his appointment post-op last week. And those are the folks who do the best because they've been so active going into surgery now, or just generally, cut back to drinking, got rid of the smoking, sleeping a little better. They can just recover a lot better from surgery.
Yeah. And I love how I love how you we used to call it bedside manner, but I really say, we're both personal development guys. You really bring the mindset into the medicine, right? And that's a beautiful pairing of that. So I commend you for that as a patient constantly.
Yeah, it's what makes it fun too. I mean, if you're the paternalistic white, no knocking anyone who likes to wear the white coat, but I hate wearing a white coat. I just feel that besides being the sweatiest guy in the room usually, I also just feel like it immediately puts distance. Yep. And when you're talking about some of the things that you have to talk about with weight loss and the personal impact on their mood and just their willingness to want to extend themselves in an uncomfortable place and go to the gym and be obviously the new person there kind of thing, like you can't have that, or it takes longer to have that conversation if you are stodgy and two steps above them in your white coat and everything.
Yeah, absolutely. We talked about this, men, right? Like we wait till there's a problem, right? Like we wait to get healthcare until there's a problem, and I think the more you're making that rapport and make it easier, you're going to see a lot more people, and that's an important thing for the patient, because you're right. Oftentimes it feels like you're sitting in the principal's office waiting to get in trouble, and
I thought about that. That's funny.
And it's so pivoting. You obviously great physician, but there's a big entrepreneurial side to you. So where is Admire Medical going over the next 2 to 5 years?
I mean, this is the most exciting question. Right now, we are kind of branching into a few of the areas that we've been, I feel like, coiled spring. We've been ready to do this stuff for a while, but just had to get a lot of pieces in place. So, we our newest program that's ready to go is we just partnered with a compounding pharmacy in the area, so we have better access to medications at lower costs, because the number of prior authorizations I've been doing for insurance coverage for basic medications recently is driving me crazy, but it's also slowing down the care for the patient. So in an ideal world, I'd meet with a patient, or Angela, my nurse practitioner, that's kind of the point I'm going to make next, my team here, want to meet with the patient and be able to either get them that medication same day from their pharmacy or hand it to them before they leave the office. And this way there's no gap in that education component, understanding of why it's necessary to start this medication, but also, the interest and the excitement about it, and then actually receiving that medication. So you can capitalize on all the education just provided to start to actually implement this change. So that's one thing that we had to do, is get a good relationship with the compounding pharmacy and put together a list of kind of, there's this World Health Organization list of essential medicines. Well, we have our own Admire list of essential medicines, where basically things that, because of their unique function within a certain class of medications, we're going to be using it a lot. And not that one medication works for everybody, but there's certain blood pressure medications that, as we learn more about it, oh my goodness, they actually improve mitochondrial health and can improve your response to exercise and faster control of blood sugar and lower Alzheimer's risk. So we put together this list and work with the pharmacy to have access to them quickly. In this way, that also includes some of the weight loss medications too. In this way, we're not dealing with some of the shortages or having to go back and forth with the insurance company and deal with business hours, and then it's now a week later and the patient hasn't gotten their medication and they're so frustrated they don't even want to start it anymore and kind of starting over from scratch. So we got that piece in place. Similarly, we found a lab testing group, Rupa Health, that they work with some of the core well-known labs, your LabCorp and your Quest and some of the smaller ones, and put together cash pricing for commonly ordered labs. And this way, same thing, we can order a test and our patient will then end up going to LabCorp wherever seems appropriate, but they find out their insurance is going to make them pay a copay of $200 when the test actually doesn't even cost that much.
Right.
Well, we have our own cash price we can offer them instead and say, hey, for $50 we can check your LP(a) and LDLP numbers and see, because of your cholesterol panel didn't show the risk, but we know there's something there. Let's get more information.
And that's the commodity of time too, right? Just
yes.
The fact of not having to go and get those labs, and you do them in house. And again, $50 means something to everybody, but still having that commodity of time you're getting back, you're saving them time too, which I love.
That's a really good point. Yeah, a lot of our plans are just to make each of these steps more convenient, because no matter how important something might be for our health, if you're just not able to see the time, the benefit of investing the time to get there, that's where it falls apart. And
right.
So part of that is having the same day service for a lot of these things, and it lets patients, again, capitalize on that motivation that they just got from the conversation, their understanding of the disease process. Another kind of extension of that is we have self-scheduling online now, so folks can go to admiremedical.com and if they find a program there that they think they would benefit from, or just want to speak with one of us, that they can self-schedule, meet us in the office. We have appointments available, very flexible right now, telehealth, in person. Just knowing that there are a lot of areas where we can offer benefit and really want to just be able to increase the access for patients, because especially in this area, it's really hard to find a doctor.
It is.
Even for general primary care things, and we are not a primary care practice, but in most cases, because of the diversity of our experiences, we can address discrete problems that are common to primary care or common, offshoot of primary care, where they may send you to someone for hormone replacement or testosterone replacement therapy, or do it themselves.
You're bouncing around all over the place.
That part too, yeah. Right. So not only can you not find your primary care doctor, but then if you have one and they refer you to a specialist, then you got to wait another 3 months to see your specialist. In these cases, we can typically get folks in, worst case scenario within like 2 weeks.
Yeah, and that's what I love about your you mentioned your team earlier and I know one of your goals is always to have that iconic movie like hometown doctor feel, right?
Yeah.
And that's what your team feels like when you kind of go into your office. It's very much that hometown. I don't care if you're in Wisconsin or Nebraska, but it feels like that. And I know that's important. To you because it's important to as a patient, right? Because you don't want to feel frightened when you go into your doctor's, right? You want to feel like that's your team, and that's truly the vibe that Admirable Medical gives off.
I mean, that's exactly why I showed up today wearing a hat and my gym clothes. So
That's right.
The video component of this can demonstrate that, on a Sunday I'm just as casual as anybody else, and actually during the week too I try and be a little less formal, just again to improve communication and things like that. But yeah, we really do want to have a good personal practice, and really because of the access, and we have a patient experience specialist, patient support specialist, Kelly, who makes sure that all the patients that schedule feel quickly integrated into the practice, and any questions or concerns they have about scheduling or insurance issues, whatever, she's there to help them get through those things. So by the time they come and see myself or Angela, we really have everything. They're not worried about what their copay is going to be. We've already sorted that stuff out. They're not worried about did they get their paperwork done in time, because Kelly's going to we'll be calling them ahead of time to make sure they got through all that stuff, so that our meeting can really just be the important part of why they're there. And I mentioned Angela a few times. So Angela's our nurse practitioner. She is just one stellar addition to the team, and she was an early person that joined us, and now truly a clinical partner of mine in the practice, because she complements my experience really well. She is a certified family nurse practitioner, but then also did some work with obesity medicine previously. Recently is doing a certification in hormone replacement therapies as well. We've got experience with that, but it's always good to kind of get the shining up, the polishing of that experience, just so that we can provide the best care possible. And that's going to be kind of her unique area in the practice.
I love that whole concept you have where she's kind of focusing on the women's health aspect. You're focusing on the men's health aspect, and really giving that holistic. My wife and I were just talking about this the other day, the importance of just your overall health as a family, right?
Mm-hmm.
Not just as an individual and things like that. So that's something else that I think we get out of Admirable Medical, which is phenomenal.
Yeah, and you got to feel comfortable with your provider. So as much as I like to think that I'm approachable and things like that, some women are just more comfortable speaking about women's health issues with a female provider, and I totally understand that and don't blame them at all. And in some cases, the opposite, of course, being true too. A guy doesn't want to speak with a woman sometimes that he just met and talk about his erectile dysfunction and his poor libido and his difficulty with mood and energy and things like that because of his low testosterone or depression or whatever it might be. Yeah. So it's good to have that variety of experiences, and also just diversity of demographics in the office too, because we bring our patient care expertise based on everything that we've done to get here, kind of thing.
So let's, as we kind of close out this episode, tell us about what's coming up. I know we're going to talk about the book, but just give us a flavor of what's coming up.
Right. Yeah. So I started that and then got excited about the other stuff. So we have the labs, we have the medication aspect of things covered, self-scheduling. So all those pieces of convenience are there. So now we just add this core weight loss challenge. So if you meet the only requirement is a BMI over 30. Just because if you're under that, then I wouldn't recommend you lose 20 pounds in 6 weeks. But if you're in that area, you can do this challenge, lose 20 pounds in 6 weeks with a combination of nutrition, exercise counseling, pain management, whatever's going to slow you down, and then weight loss medications as appropriate. We can get that weight loss started, and then the whole point is that because you've had a good experience over 6 weeks, well, then you can continue those things for life. So it's not going to be a beach body boot camp, one and done kind of thing. It's here's how you have foundational change. So that's one program that we want to start, because it's going to be a good defined and set a goal, meet a goal. You get that reinforcement of success. All right, well, what can we do next kind of thing. So we have that program. We have a bunch of different mean, it's one umbrella of prehab, but we work with different providers in the area to offer prehabilitation for those services. Moving forward, we have a couple areas that we want to extend into based on our logical experience. So we have someone who's going to be joining us in the office as a separate practice, but she has massage therapy. So we have that just geographically adjacent for patient convenience. You're working towards surgeries, you need to relax. Well, we know a couple massage therapists in the area, and one of them happens to be in the office with us here. Other programs that we're going to begin in the future, trying to think of a good one. I'm so focused on the weight loss one, I forgot about the other stuff that we're doing. So another program that we're going to be working on in the future here, that's, again, we're putting the pieces together right now, is a good prehab kit. So we know a lot of folks, I mean, someone like you or me, who have good confidence with exercise, nutrition. We know what we need to do. We just need a kind of organized plan of how to do it. That's what these prehab kits will be for. It's going to be, there'll be a couple different tiers of it, more or less. An all-digital component, you just need the information, you can do the rest. All right, well, this one, the next step up might have some home exercise equipment and a plan that we're putting together with that one. Working with a physical therapist right now who's writing that out for us as we speak. And there are, of course, nutritional recommendations, and we tailor these based on whatever your personal nutritional requirements or restrictions might be. And then within each of these is a copy of the prehab book that's coming out here. So we have the patient version coming out, like I said, and it will include video lessons of the chapter that applies to them.
Nice.
So walking everyone through, again, say you're coming in for joint replacement, talk about the unique aspects of prehab for joint replacement, what are common issues to consider, what are the most important factors for optimization. You have 6 weeks, you got to prioritize something, you hammer on this, and this. And this way it'll be a kind of a self-contained kit of everything you need to do for someone who is busy and self-motivated and really just needs the true resources to do it, kind of thing.
And that's important. I mean, my wife broke 5 bones in her foot about 5 years ago, and major surgery to her foot and kind of reconstruction, and again, the great experience. And when we were sent home, it was kind of a pamphlet, and here's your nerve medication, and and we'll check in as we need. But your point is, you kind of take the scary out of surgery, right? Mm-hmm. Is this? It's more of a. It's also, again, going back to that mindset word, right? It's you're kind of stepping them through the process as well, and giving them that certainty they probably need as they're going through this really scary thing they've never been through before, and that's the other great piece of that.
You're very good at pulling out the points that I forget to touch on. So yes, the last really cool part of why we did both books actually is by laying out the full continuum of care. There are no surprises. So there's some conditions where you should anticipate going to inpatient rehab afterwards. There's some conditions where no, you should anticipate going home, and here's what complications you want to look out for. Or before that, here's who your treatment team is going to be. Say you've been diagnosed with cancer, and you're like, what the heck is the difference between a surgical oncologist, a radiation oncologist, a medical oncologist? Like, why do I have all these people? Should I see palliative care? Do I not need to see palliative care? To have something that at least spells it out and gives you a direction in which you can go in, like that, the education demystifies the line, makes it a lot more comfortable going into what is an otherwise really serious treatment or diagnosis or whatever it might be. So that's the last piece of why we did that, for sure.
All right. Well, we have come to the end, my friends, and we are going to continue these, and Dr. Alex is going to dive deep on the continuum care process for you, and share this for us, please.
Definitely. Thanks, Mike. This is awesome. Appreciate it.